Hello everyone and welcome to our module on hyponatremia. The normal sodium concentration in human plasma is between 135 and 145 milliequivalents per liter, and when the plasma sodium gets outside this range we call that either hypo or hypernatremia. And in order to understand the symptoms that patients develop when they have hyper or hyponatremia, you need to appreciate that the plasma sodium concentration has significant effects on the brain. When the plasma sodium level gets low, this causes low plasma osmotic pressure. We'll talk about osmotic pressure in more detail on the next slide, but this is the pressure that controls the movement of fluid in and out of cells. So when there's low sodium and hyponatremia, there's low plasma osmotic pressure, and that causes fluid to move into cells, and therefore brain tissue and brain cells will swell. Conversely, when the sodium is high, this leads to high plasma osmotic pressure, and this causes fluid to move out of cells, and brain cells and brain tissue will therefore shrink. So because of these effects on the brain, when patients develop hyper or hyponatremia, the symptoms they develop are typically symptoms related to the central nervous system, symptoms like malaise, stupor, coma, or nausea. We'll begin our discussion of hyponatremia by talking about plasma osmolality. Plasma osmolality refers to the amount of solutes that are present in plasma, and this is very important for determining water movement in and out of cells. If the plasma osmolality is high, then water will be drawn out of cells into the plasma. If the plasma osmolality is low, then water will be drawn into cells. And the most important solute for determining the plasma osmolality is sodium. If you look at the bottom of the slide, this is the equation for serum osmolality. It's equal to 2 times the sodium concentration plus glucose over 18 plus BUN over 2.8. And the normal value for serum osmolality is 285. Now I just told you that the normal sodium concentration is 140. So 2 times 140 is 280, so most of this 285 value for serum osmolality comes from sodium. And so because sodium is so important for serum osmolality, the osmolality should always be low anytime you have hyponatremia. If the sodium level falls, that should lead to a fall in serum osmolality. So the first step in evaluation of hyponatremia of unknown cause is to make sure the serum osmolality is low. We can easily measure the serum osmolality of plasma in the laboratory, and it should be low when a patient has hyponatremia. If you have a patient with hyponatremia, but you send a sample of plasma to the lab, and the lab analyzes it and tells you the osmolality is high, then that means there must be some osmol floating around in the plasma. And there are two situations when this happens. One is in patients with hyperglycemia. The other is in patients being treated with mannitol, which is a drug used to raise plasma osmolality. Glucose and mannitol are osmoles, so they raise the osmolality of plasma, and they draw water out of cells. So when they draw water out of cells, this dilutes the sodium concentration and causes hyponatremia. However, when you analyze the plasma for osmolality, it will be high, and the reason it's high is because the glucose or the mannitol is making it high. And so this is the explanation anytime you have hyponatremia with high osmolality of plasma. If you have a patient with hyponatremia and you send a sample of plasma to the lab and the lab tells you the osmolality is normal, then that means this patient has either very high lipids or very high protein levels. If the lipids or the protein levels in plasma are high, this causes an artifact in the laboratory technique used to measure the serum sodium, and it will make the serum sodium level appear low, even though there is in fact nothing off in terms of serum sodium. This is called pseudo-hyponatremia. The patient really does not have hyponatremia. It's an artifact of measuring the sodium level when hyperlipidemia or hyperproteinemia are present. And of course, multiple myeloma is the classic pathologic condition where high protein levels in the blood interfere with measurement of serum sodium and make it artificially low. So putting this all together, measurement of the plasma osmolality is the first step in evaluating hyponatremia of an unknown cause. If the plasma osmolality is high and you have hyponatremia, then that means that patient has hyperglycemia or they are being treated with mannitol. If the patient has hyponatremia and the plasma osmolality is normal, then that patient has high levels of lipids or proteins in the blood. And then finally, if the patient has hyponatremia and the plasma osmolality is low, then that means you have true hyponatremia, and that means you need to do further workup to understand the underlying cause. To begin our discussion of true hyponatremia, let me go over some general points about how the body responds to low serum sodium. So hyponatremia is really not a problem of too little sodium, it's a problem of too much water. When there's too much water in the plasma, that dilutes the serum sodium and the level becomes low. So anytime there's too much free water in the plasma, the kidneys will respond by trying to excrete as much free water as they can, and this means that the urine should be diluted with more free water than solutes. The normal osmolality of urine ranges from as low as 50 to as high as 1200, depending on whether the kidneys are trying to excrete or retain free water. In the setting of hyponatremia, the urine osmolality should be very low. It should be under 100 because the kidneys are trying to get rid of all that water that is present in the plasma. If the urine osmolality is not low, that implies a problem, and we'll talk about that in a minute. In addition, the urinary sodium should also be low in the setting of hyponatremia. Once again, this is because the kidneys are trying to dilute the urine and maximally excrete free water, so you should get a very low value for urinary sodium, and a low urinary sodium is generally considered less than 30 milliequivalents per liter in the urine. The hormone that controls the amount of water in the plasma is antidiuretic hormone, also called ADH or vasopressin. This hormone is released by the posterior pituitary gland, and it goes to the kidneys, and it tells the kidneys to reabsorb water from the urine. So anytime there's lots of ADH around, lots of water is going to get reabsorbed from the urine. This is going to make the urine relatively concentrated. And so you can understand most of the causes of hyponatremia if you just appreciate that any cause of high ADH is going to cause hyponatremia. If anything goes wrong and the ADH level is always high in the body, then sodium levels are no longer being controlled by ADH because it's always high. The plasma-free water is going to vary with water intake. Basically, all the water that you take in is going to be retained by the kidneys, and most of us drink more water than we lose in a day, and therefore when we take in that excess water, that will lead to hyponatremia. A high ADH level also leads to a concentrated urine. Once again, urine osmolality can range from 50 to 1200. It should be low in patients who have hyponatremia if the kidneys are working normally. However, if the patient has a high ADH level, the urine will be inappropriately concentrated. And a concentrated urine in the setting of hyponatremia always means there's high ADH around, and that shouldn't be the case, and that means some pathologic process is causing the ADH level to be high. The most common trigger for high levels of ADH is hypovolemia. If the arterial system is underfilled, that will activate the renin-angiotensin-aldosterone system, and this system can activate the pituitary gland to increase its release of ADH. So any patient who has hypovolemia is going to have a high level of ADH, and that's a setup for developing hyponatremia. There are two important pathologic conditions where the body perceives hypovolemia, even though in fact there is an excess of total body water. In these conditions, there's an underfilling of the arterial system, although, as I said, the whole body is overloaded with fluid. And these two conditions are heart failure and cirrhosis. So these patients are generally swollen with fluid in their abdomen or in their lungs, but their arterial system is underfilled, and that is perceived by the body as hypovolemia. So these things are going to lead to chronically elevated levels of ADH, and therefore patients with heart failure and cirrhosis commonly develop hyponatremia if they drink more water than they lose in a day. The other way you can get chronically elevated levels of ADH is if you have true hypovolemia, and many patients with true hypovolemia from one of these causes here develop hyponatremia. So patients on diuretics can develop hypovolemia that can activate the RAS, which can increase ADH levels, and this can lead to hyponatremia. Thiazides are the classic drug to do this because they increase ADH levels, but they do not disrupt the ability of the kidneys to reabsorb water. So you get high ADH levels and very vigorous water reabsorption by the kidneys in patients on thiazide diuretics, and that's a perfect setup for hyponatremia. Patients with GI losses of volume, for example, patients who are vomiting or who have diarrhea, these patients will have high levels of ADH from the RAS, and therefore if they drink free water, they easily become hyponatremic. And then lastly, patients who are sweating or exercising will lose volume and the RAS will become activated, and this raises ADH levels. So if these patients are drinking free water and not something like Gatorade that has electrolytes in it, they can easily become hyponatremic. There are also two rare conditions that can lead to chronically elevated levels of ADH, and those two conditions are adrenal insufficiency and hypothyroidism. So cortisol from the adrenal glands normally suppresses ADH release to a mild degree from the pituitary gland. So if you lose cortisol secretion from the adrenal gland due to primary or secondary adrenal insufficiency, the level of ADH will get high. In addition, patients who have primary adrenal insufficiency will also lose aldosterone secretion from the adrenal gland. This will cause them to lose salt and water and become volume depleted, and that also raises ADH levels. And then finally, through poorly understood mechanisms, hypothyroidism is well described as increasing levels of ADH, and therefore many patients with hypothyroidism develop hyponatremia. If you don't have any of the disorders I mentioned on the last two slides, but your ADH level is still high and that's causing hyponatremia, then what you have is the syndrome of inappropriate ADH secretion, otherwise known as SIADH. As the name implies, SIADH causes hyponatremia due to inappropriate ADH release. And in order to have SIADH, you can't have any of the causes we mentioned in the last few slides. So you can't have heart failure, cirrhosis, you cannot be volume depleted, and you cannot have thyroid or adrenal disease. In addition, you have to have normal kidney function. You must be euvolemic, meaning you cannot be volume depleted or volume overloaded. And finally, you have to have a high urine osmolality, which is greater than 100. If a patient has hyponatremia and a high urinary osmolality, that tells you that the ADH level must be high. That's what makes the urine concentrated like this. And then if there's an absence of all of these other causes of high ADH, then the diagnosis is made of SIADH. And there are many, many causes of SIADH. You can read about these. I've listed some of the important ones on the slide here. There are drug-induced causes. Two of the classic drugs to cause SIADH are carbamazepine and cyclophosphamide. Patients with small cell lung cancer often develop SIADH as a paraneoplastic syndrome. Disorders of the pulmonary system and the brain often cause SIADH, so patients with stroke or head trauma or infection of the central nervous system, these patients often develop hyponatremia from SIADH. The same is true of patients with any pulmonary disease, especially pneumonia. Many pneumonia patients develop mild hyponatremia from SIADH. Most of the causes of hyponatremia are related to high ADH, as we have been discussing in the last few slides. But there are a couple of causes of hyponatremia that are not related to ADH, so let's talk about those now. And the important non-ADH causes of hyponatremia are renal failure, psychogenic polydipsia, and special diets. Patients with advanced chronic kidney disease commonly develop hyponatremia, and the reason for this is because their kidneys are sick and cannot excrete free water normally. So remember that I told you earlier that urine osmolality ranges for healthy kidneys from as low as 50 to as high as 1200. Well, for patients with advanced chronic kidney disease, they can't get it as low as 50. Their kidneys are not healthy enough to dilute the urine down to that level. So the minimum urine osmolality that they can achieve, instead of being 50, may be 200, or may even be as high as 250 or 300. This makes it hard for them to excrete free water, and therefore, if patients with chronic kidney disease drink lots of water, they can easily become hyponatremic. And I've summarized these points here. Their urine cannot be diluted. The minimum urine osmolality rises even when the ADH level is low. They won't be able to get down under 100 like healthy kidneys. They may be only able to get down to 200 or 250 because of renal failure. And an important point here is that, as we said before, when you have hyponatremia, if you have a urine osmolality that is not at the bottom of the range, in other words, down around 50, then something is wrong. And that's what happens in chronic kidney disease. The high urinary osmolality in the setting of hyponatremia means there's an abnormal response to hyponatremia. And these patients can develop euvolemic hyponatremia, or in some cases they will be hypervolemic. If they have advanced chronic kidney disease and have serious trouble excreting volume from their body, then they can even be hypervolemic. Psychogenic polydipsia occurs when you drink so much water that you develop hyponatremia. Now, healthy kidneys can excrete lots and lots of free water, so you really have to drink a lot of water, more than 18 liters per day, if you want to develop hyponatremia just from drinking too much water. This usually occurs in psychiatric patients who have some type of compulsive disorder where they are constantly drinking water throughout the day. And the most important clinical finding that will tell you that the diagnosis in a patient with hyponatremia is psychogenic polydipsia is that the urine osmolality will be low. Remember that when the urine osmolality is low, that means the kidneys are working. They are trying to eliminate free water. The urine is becoming maximally dilute. So if a patient has hyponatremia, despite the fact that the urine osmolality is very low, then that means it must be something outside the kidneys causing hyponatremia. And usually that means they're either drinking too much water or they're drinking too little solutes. We'll talk about that in a second. So in these patients with psychogenic polydipsia, you identify the hyponatremia, you find the low urine osmolality, and then you recommend water restriction, and this will resolve the hyponatremia because there's no problem with the kidneys. It all has to do with the patient drinking too much water every day. So one way you can develop hyponatremia through your diet is by consuming way too much water. But another way you can get hyponatremia through your diet is by eating very little sodium. There are certain special diets that contain so little sodium that they can lead to hyponatremia. One of the classic diets to do this is the tea and toast diet. Some people go on this diet to lose weight, and it contains very little sodium. Many beer drinkers consume very little sodium, and they develop a form of hyponatremia, sometimes called beer potomania. The problem with both of these diets is that they contain very little sodium. So you may be asking yourself, why is it that very little sodium ingestion leads to hyponatremia? Well, to understand this, remember that we've already talked about the fact that the minimum osmolality that the kidneys can achieve is about 50 milliosmoles per kilogram. So a way you can think about this is that for every 1 liter of urine the kidneys want to produce, they must come up with 50 milliosmoles of solute, including sodium. So if you are eating very, very little sodium, then you cannot excrete many liters of water because you need to pair every 1 liter of water with 50 milliosmoles of sodium. So in patients who consume very, very little sodium intake, they become limited in the amount of free water that they can excrete. This sets them up for a situation where they can easily consume more free water than they are putting out each day, and as a result they develop hyponatremia. Just like patients with psychogenic polydipsia, patients on one of these special diets that consume very little sodium will have a low urine osmolality. And remember, whenever the urine osmolality is low in the setting of hyponatremia, that means the kidneys are working. They are trying to eliminate free water, but something is keeping them from eliminating the amount of free water that is necessary to avoid hyponatremia. And in the case of special diets, the problem is that the free water excretion by the kidneys is limited by the small availability of solutes because the patient is not consuming much sodium. So I just want to emphasize this point about both psychogenic polydipsia and special diets. These are situations where the patient will have hyponatremia and a low urine osmolality. This indicates that ADH levels are low and that the kidneys are working, trying to excrete free water, but they cannot. So the diagnosis when there's hyponatremia with low urine osmolality must be either psychogenic polydipsia or a special low solute diet. In all the other causes of hyponatremia we've discussed in this video, the urine osmolality is high because there's some problem with the kidneys or some problem with ADH and its function. Some sources like to classify the causes of hyponatremia by volume status. This is not my preferred way to do it, but if you want to do it this way, shown on this slide is a table with the different causes of hyponatremia based on whether the patient is hypervolemic, euvolemic, or hypovolemic. Patients who are hypervolemic with hyponatremia have either heart failure or cirrhosis, or very rarely they can have severe renal failure where not only have they developed hyponatremia, but they are retaining fluid and have developed fluid overload. At the other end of the spectrum, hypovolemic hyponatremia occurs in patients who are volume depleted for any reason. This could be from sweating, this could be from vomiting and diarrhea, this could be from hemorrhage. You also commonly see hypovolemic hyponatremia in patients on diuretics. And then very rarely, if a patient has Addison's disease, which is primary adrenal insufficiency, these patients lose the ability to produce aldosterone from the adrenal gland and therefore they waste salt and water and they will become volume depleted, and those patients easily develop hyponatremia. Most patients you will see who are euvolemic with hyponatremia have SIADH. This is very common, and when the patient is euvolemic, this is the most common cause. As I said before, patients with renal failure can be euvolemic and develop hyponatremia. Thyroid disease is always in the differential of hyponatremia. It usually causes euvolemic hyponatremia. And finally, those rare causes we talked about like polydipsia and special diets cause euvolemic hyponatremia. So there are lots of potential diagnostic tests that can be part of the workup for hyponatremia. But on this slide, I've summarized some of the most important elements of the workup of hyponatremia, and these are the things that usually lead to the diagnosis in most cases. So first of all, the history and physical exam are crucial. If the patient has a history and an exam consistent with heart failure or cirrhosis, then that is probably the cause of hyponatremia. You also can determine by history if the patient has been taking diuretics and if the patient has had anything that may cause volume loss like vomiting or diarrhea. You always want to check a serum glucose in patients who have hyponatremia because if the patient has a very elevated glucose, then as we talked about, that will cause hyponatremia by drawing water into the plasma. You always want to know the BUN and creatinine in your patients because if they have advanced chronic kidney disease, that can cause hyponatremia. And then finally, as I said on the last slide, in patients who are euvolemic with hyponatremia, they usually have SIADH, and this can easily be confirmed by checking the urine osmolality and the urine sodium. Both the urine osmolality and the urinary sodium will be inappropriately high in the setting of hyponatremia, and that's how you make the diagnosis of SIADH. For the vast majority of patients you will see with hyponatremia, you don't need to do any other treatment besides identifying and treating the underlying cause. So in patients with pneumonia, when the pneumonia gets better, their hyponatremia will get better. In heart failure patients, if you improve their heart failure status, then the hyponatremia will get better. Same thing in patients who are volume depleted. If you replace the volume they've lost, the hyponatremia often improves. For patients in whom treatment of the underlying cause isn't enough, you can use free water restriction. This will raise the serum sodium over time if the patient just doesn't take in free water. And then rarely you can advise patients to take sodium chloride tablets. This will increase the amount of sodium going into the body, and this can improve hyponatremia in severe cases. This is only done for euvolemic hyponatremia. You never want to give sodium chloride tablets to a patient who has heart failure or cirrhosis, for example, because that will worsen the volume overload that patient already has. And for patients who are volume depleted with hyponatremia, before you give sodium chloride tablets, you want to replete the volume. So sodium chloride tablets are only in patients with euvolemic hyponatremia. Hypertonic saline, which is 3% sodium chloride, can be used to raise the serum sodium. This is only done in patients with severe symptomatic cases of hyponatremia. And then finally, there are drugs that are called Vaptan drugs. They all have names that end in Vaptan, like Tolvaptan, Lixivaptan, and Conivaptan. These drugs block the effects of ADH, and the main use for these drugs is in patients who have severe hyponatremia of heart failure. These drugs have only been studied in patients with heart failure. They're not really used anywhere else, and they're only used on hospitalized patients. So the one time you would think of a Vaptan drug is in a patient with heart failure who has severe symptomatic hyponatremia. You might give that patient a couple of days of a Vaptan drug to try and improve the serum sodium before the patient goes home. There are some special things you need to know about the treatment of SIADH, so let's talk about those now. The first one is that normal saline worsens the hyponatremia of SIADH. This is super high yield. It comes up on board exams. It comes up on rounds. So many patients have hyponatremia from volume depletion, and when you give those patients normal saline, you correct the volume depletion and the hyponatremia gets better. So because we see normal saline fixing hyponatremia all the time, it's logical to think that it would also correct the hyponatremia of SIADH, but this is not correct. And the reason this is not correct is because these patients always have an excess of ADH effects around, even when their volume has been increased by normal saline. With volume depletion, normal saline turns off the high ADH, but that does not happen in SIADH. These patients always have high ADH levels, and that causes them to retain free water. So when you give them normal saline, they will excrete the sodium faster than they excrete the water, and this will cause the hyponatremia to get worse. The reason this happens is simple math. The urinary sodium concentration is always high in patients with SIADH, and it's higher than the sodium concentration of normal saline. So let's imagine we have a patient with SIADH, and they are making inappropriately concentrated urine, which has a concentration of 500 osmoles in 1 liter of water. The urine for this patient will always have this high concentration even after you give normal saline because ADH levels are always high no matter what because of SIADH. Now let's imagine you give them sodium chloride. So you give them 1 liter of free water with 300 osmoles in it because that's the osmolality of normal saline. So now let's imagine this patient makes 1 liter of urine per hour. Well, that means in 1 hour they will excrete the 1 liter of free water that you gave them with sodium chloride. But to excrete the 300 osmoles you gave them with sodium chloride will take less than an hour because they're excreting 500 an hour. So the idea is that they excrete the sodium more rapidly than the water, and that causes the hyponatremia to get worse. For example, imagine this patient had hyponatremia with a sodium level of 130. If you gave them normal saline, it would drop to some lower number, for example 125, because the patient would excrete the sodium faster than the water. Now eventually they would also excrete the water and the sodium would come back to 130, but the bottom line here is that by giving them sodium chloride, you do nothing to fix the hyponatremia, and in fact you temporarily make it worse. Another special thing to know about SIADH is that it can be treated with an antibiotic called demeclocycline. This is only done in patients who have chronic SIADH with chronically low sodium levels. Demeclocycline is a tetracycline antibiotic, but it has a chemical structure that causes it to antagonize ADH receptors in the kidneys, and for this reason it can raise the serum sodium in patients with chronic SIADH. The last thing we'll talk about under the topic of hyponatremia is central pontine myelinolysis. It's also called the osmotic demyelination syndrome. This is a very severe brain condition that occurs if you correct hyponatremia too rapidly. It usually happens if you raise the serum sodium concentration more than 10 milliequivalents per liter over 24 hours. So remember that a normal serum sodium is 140, so imagine that you are treating a patient with severe hyponatremia of 120. You don't want to convert that 120 to 130 in less than 24 hours. If you do, your patient could develop central pontine myelinolysis. In this condition, there's demyelination of central pontine axons, meaning axons found in the pons of the brainstem. This leads to a lesion at the base of the pons, and patients lose their corticospinal and corticobulbar tracts, and these are the tracts that allow motor control over the head and neck and the rest of the body. So these patients will develop quadriplegia. It can look very similar to a locked-in syndrome where patients are unable to move or speak. And if you look at this MRI on the screen, this is the pons here, and you can see this white area in the middle of the pons. That's what happens when patients develop central pontine myelinolysis. This is a life-threatening condition, and for this reason, we never correct hyponatremia too rapidly. And that concludes our module on hyponatremia.